Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer and a few other things that's been working with CCF for 10 years. I think it's 11 or 12 now. Who knows anymore after the past couple of years, but a long time, over a decade. And in that span of time, we've created, I really need to calculate how many videos, but hundreds of videos that I would say, including live video series and conversations like the one you're going to watch today, patient-centric documentaries. We have one of those coming out this month, treatment-based videos, conference and event videos, all kinds of videos, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do. Now, this show, Luncheon with the Experts, the value is really twofold. One, you're going to get some interactive time with a leading specialist in this space and hopefully answer some questions that you have. And two, and I say this every week, and I can't reiterate it enough, the shared experiences and shared stories of the community itself. This net community is extremely strong, extremely supportive. So if you are new to this journey and new to the show, first of all, I want to say welcome. And I want to encourage you to embrace the community. Reach out, introduce yourself. I promise you they will embrace you back. And you can see the people who are regulars to the show are already chiming in, saying hello, letting us know where they're from. Canada is always in the house with strong representation. So we see that already as the numbers continue to grow. So let us know where you're signing on from in the world. It's one of my favorite things to see how far this program reaches, especially live when people are in countries that you would think they would be going to sleep. They're staying up for the show. That says a lot about the work that we do. So before we get started with today's show, we want to thank the sponsors because simply without their support, we wouldn't be able to do the show, Ipsen Biopharmaceuticals. But we have this disclaimer from them, and that is that the opinions expressed by the guest presenters today, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest today and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that last line is really the takeaway. We're going to give you some good general advice, some good answers to your question, but by no means do we or our guests know your specific case. So take that advice and those answers back to your home team, which does, and make the best plan and path forward for you. Because though I am not a medical expert, the one thing I have definitely learned in the past 10 years of working with this disease is each case is unique, and therefore each plan and path forward is as well. Today, I'm very excited to welcome back to the show. It's been a little while, but she has been here before. Dr. Alexandra Gangi. How are you, Dr. Gangi?
I'm doing well. Happy to be here.
Good. Dr. Gangi is out there in sunny California. For those that aren't familiar with the work that you do, can you tell us a little bit about yourself, where you work, and the role that you fill in this net community?
Sure. I am, as Rain mentioned, I'm in Los Angeles at Cedars-Sinai. I'm a surgical oncologist focusing in GI tumors, and specifically with respect to NETs, I focus on small bowel and pancreatic neuroendocrine tumors and management of metastatic disease, especially liver metastases in that setting. And then here I also help run our surgical oncology fellowship, so hopefully training some other people to be involved in treating NETs and finding good answers for all of the patients out there as we move forward.
Interesting.
Interesting. I don't know, Rain. What does that mean?
I want to learn. I have some questions lined up. Okay. I get to squeeze in a couple too when we have this show. Let's go ahead and do it though. So with the fellowship, what I'm interested in is, working with this disease for 10 years. I've seen the kind of the leading doctors change. There was kind of this old guard, and we like to feature a lot of the newer, younger doctors on the show. And so I've seen how much this disease has, or at least our ability to diagnose and treat this disease has progressed in the past 10 years. So I'm interested, when you're teaching people now coming into the field, what are the main things? Obviously it's a lot that you have to cover, but what are you focusing on them understanding most about this disease specifically?
Good question.
Isn't it?
So I think realistically, when trying to teach them in terms of management of NETs, it usually is centered around a patient that we've seen in clinic or, in the hospital setting. So frequently it depends on the primary tumor, the location of the metastases, if they have metastatic disease, and then kind of trying to have them do a little bit of research on their own or understanding what their background understanding of management of neuroendocrine tumors are, and then adjusting that. So a little bit of historical perspective, updating them in terms of current management, current mechanisms, providing them with some recent literature if it's applicable, making sure if it's someone who needs to go get PRT, saying, hey, have you heard about the Nether trial? Do you know what this is? Have you heard about Roan? Have you heard about clarinet? With respect to pancreatic neuroendocrine tumors, some major trials that showed the efficacy of different types of chemotherapies and why we use one versus the other, the role of somatostatin analogs. So there's a lot to cover, but a lot of it is kind of patient-based. So they train over the course of 2 years, and we're lucky in that we have a fairly robust neuroendocrine tumor practice. So I think by the end of the 2 years, they've seen enough variations and enough patients where they're pretty well versed in kind of historical perspectives, current management perspectives, different options and algorithms for treatment. And then there's obviously what we do in the operating room. So that's more kind of anatomic
that part.
Training, and that's not always as net specific.
Right.
When we're resecting liver tumors, we resect liver tumors the same way for the most part. If we're doing wedges and enucleations, if we're doing pancreas procedures, it's essentially the same, depending on location of tumor. So lots of nuances there.
Got it. Thank you. Yeah, there's a lot of new activity going on right now. It's kind of exciting times. Maybe we'll talk some about that later today. Folks, so here's the deal about this show. Before we fully get started, go ahead and start sending in your questions, though. I like to have them queued up, so when I finish my little bit of housekeeping and announcements, we can launch right into it. So send in your questions, but here's a couple of tips that's going to help me do my job better, which is, of course, to get those questions answered. We don't know your specific case. I've already mentioned that. And we can't answer very case specific questions because of that fact. So try to formulate your questions in generic terms, right? If it's super dense and super specific to your case, sometimes there are paragraphs, and paragraphs can be really hard to field that question. But two, there's so many nuances and details that need to be known. It's not going to really help us get that question answered. So I know you have lots of questions. So if you do, think about delivering them in little chunks. Get this question answered that will lead to the next one and lead to the next one, and ask them that way too. Sometimes people try, and I understand the thought behind this. They try to put 3 or 4 questions within their comment, and that actually makes it a little bit more difficult. So that would help me. And you always can feel free to chime in if there are follow-up questions that are spawned from the answer that you receive from Dr. Gangi. Ask that follow-up question. Just give me a little bit of context so that I can remember your question from before. Now, we may not get to all of them, and inevitably we don't, because we get so many. So if we don't get to your question, or if you have follow-up questions, you can always reach out to CCF here on the Facebook page where you are. Just send them a private message, or you can reach them at carcinoid.org, their website. If you see a question in the comment section that you also have, or you're interested in the answer to, there's a little like button. It gives you a couple of motions you can use. They all work the same way for me. You can like that question, which just shows me that you also, want the answer to that, i.e. there's a demand for it. And as I said, as I'm combing through the questions and I see 8 people have the same question, I'm going to make sure to get that one across. So that helps me do my job, which again is to get your questions answered. And last thing before we fully get started, as soon as the show is done today live, it will be posted on the Facebook page. It'll be evergreen. You can always access it there. If you want to replay it starting Monday, we will put it to YouTube for those who don't have Facebook. If there's anyone that should be here right now, because the real value is this interactive one-on-one session that you get, tag them in the comments. Let them know. Remind them that the show is going on. Let's try to get as many people here as possible. I'll start scrubbing through the questions, and we'll start taking them. One thing that I had off the bat, Dr. Gangi, I'm always interested in talking to surgeons about this. I know through just my experience with the show and working with the disease that sequencing is always, a question mark. As a surgical oncologist, are you always surgery first?
No, I am not always surgery.
What factors determine your approach there?
Primary site, degree of disease. With respect to degree of disease, meaning if someone has a metastatic tumor, where are the additional metastatic sites? Are they metastatic to lymph nodes? Are they metastatic to the liver and the lymph nodes? Are they metastatic to the bone, the lung, the liver, the lymph nodes? Is it something that if we were to do surgery, we would be able to essentially get rid of all of it? Stability of disease or progression of disease, meaning how quickly have things changed? Is this a new diagnosis or not a new diagnosis? Have other therapies been attempted depending on that degree of disease question? I mean, this is very broad, so I'm thinking of the entire gamut. So sometimes we get newly diagnosed early stage patients who have an isolated primary tumor, and in that case, almost always surgery is the right answer. Everything outside of that, no, we have to consider sequencing of therapy, extent of surgery, and what additional options we have available.
Got it. Thank you very much. Okay, questions are rolling in as I anticipated. Let's go ahead and start taking some from the audience. Eva says, I didn't have a gallium 68 prior to surgery. Would they be able to test for receptors on the frozen pathology sample?
Not necessarily, but typically depending on your final pathology result, typically well-differentiated neuroendocrine tumors will be somatostatin receptor positive. Can I ask you a question back?
Yeah, certainly.
Yeah. Okay. I don't know. I can't see anyone.
I'll deliver. I'll deliver.
Okay. Thanks. Good.
They can also hear you.
Yeah. So I'm assuming in asking that question and asking if you could evaluate for it on the pathology means that there's potentially no other sites of disease. And why are you concerned about knowing if your somatostatin receptors are positive or not?
Got it. So Eva, when you answer that and chime back in, just give me a little bit of context, say your receptors, pathology, just remind me of your previous question and we'll try to get that fully answered for you. So next question comes from Jody. Is it common to need a full pancreatectomy after a distal pancreatectomy after PNET resection?
It is not common, no.
Oh, thanks, Jody. Let me know if you have another question. From Chris and a couple of people. How does having liver embolization before debulking surgery affect or impact the surgery?
Depending on the specificity of the embolization. So essentially an embolization, we know that neuroendocrine tumors that metastasize to the liver are typically supplied by the hepatic artery, which is why we're able to do hepatic artery embolization for these tumors. And there's a few different types of embolization that can be done. And there's different mechanisms through which you can do that. So, and sometimes it depends on the degree of tumor you have within your liver. So sometimes what we could do, if you have a lot of disease in your entire right lobe of the liver, some centers may embolize the entire right lobe. But if we're able to get to more specific arteries that are feeding the exact tumors, then you're embolizing the specific arteries that are feeding those tumors that are coming off of the main right hepatic artery. So at the time of surgery, if you've had a previous embolization, sometimes what we see is kind of more fibrosis, meaning more firmness of the liver immediately surrounding those tumors, if we're trying to get to them and kind of enucleate them and pull them out. If we're doing any kind of formal resection and we're trying to get around the vessels before we do the resection, then sometimes depending on the material used for the embolization, that can be a little bit more tricky because there's kind of firmness and scarring around those vessels. Typically, it doesn't necessarily have a major impact before a debulking surgery, but it can. The one caveat there is in patients who require a Whipple procedure or essentially a pancreatic duodenectomy, a lot of times we won't consider those patients for embolization procedures down the line because you have a very high risk of developing abscesses in the liver after an embolization procedure, because the way we reconstruct you, you essentially have a direct feed of part of your liver draining biliary duct into your small intestine. And so there's a high risk of seeding. So sometimes if a patient needs a Whipple and also needs an embolization, we prefer to do the embolization first and then do the additional procedures after, because the converse is quite risky for risk of infection.
Got it. Thank you. And thanks for your question, Chris. Next question comes from Rebecca. If surgery is not possible on liver metastasis at this time, does a Y90 performed in the liver preclude a future debulking surgery?
The short answer is no. But the longer answer, I think, is it depends on the degree of Y90 treatment, how you respond to it, how much fibrosis you may have down the line, and ultimately your response to all those therapies. It's similar to kind of embolization and what I was mentioning with respect to the fibrosis and the firming up, and sometimes making the operation more complicated. And sometimes the Y90 treatment, given that we're giving you radiation, although the distance that the radiation should travel from the beads emitted is fairly small, it depends again on the degree or the size of the tumor that we're treating, and what your overall liver health is down the line. But that's true for any treatment. Sometimes we give you chemotherapy and it affects your overall liver health. Sometimes it's liver directed therapy that affects your liver health. So we need your liver to be healthy enough to tolerate the operation. And that's one thing to always consider as well.
Got it. Thanks, Rebecca. Next question from Samantha. I've heard that liver embolization can reset the clock. What exactly does that mean?
So the term resetting the clock is something we like to use not infrequently when managing neuroendocrine tumors. And the thought is, even in respect to debulking, embolization, any kind of liver-directed therapy, resection of primary tumors, we believe, based on primarily retrospective data, meaning a lot of these things are things that we look at in retrospect. So we've had a bunch of patients that we've treated in a certain fashion, and then we wonder, is it better to do this or is it better to do that? And instead of answering it prospectively, meaning I take two of you and I say, I'm going to put one of you in this group and I'm going to put the other one in this group and I'm going to see what happens in 5 years. We say, well, we've done both of these things, so let me look historically at how patient A versus patient B did. That's what we mean by retrospective. But we have some evidence that essentially shows that there's a benefit in treating, embolizing, resecting, et cetera, these different things. And what is the benefit is essentially you may have slower progression of your disease and you may have longer survival times. So when we look at those two metrics specifically, we say, oh, well, we think there's a benefit in doing embolization therapy or resection or et cetera, in the sense that it helps us slow the disease process and reset the clock. That's kind of what we mean.
Got it. Thank you.
Yep.
From Michael, is the liver considered to be gastrointestinal?
Yeah, I mean, in some sense, it's hepatobiliary, but yeah, hepatobiliary falls within gastrointestinal. I guess the question would be, I'm assuming, is it because you're wondering if you have a gastrointestinal net or what specifically? I'm happy to answer that further, but yes, it's part of the GI system.
Got it. Hey, thanks, Michael. Let me know if there is a follow-up question there. We've got Dr. Gangi for 41 more minutes. Next question from Rebecca and many other people. Does this cancer always go to the liver eventually? Once you have surgery and have the lymph nodes removed, how does it still spread?
So the liver is the main draining organ of everything in your abdomen. So there is a vein that essentially goes from your small intestine, and another vein that goes from your pancreas, and everything dumps into the liver. So before blood flows back into your heart, it has to go through the liver. So if there's cells from any tumor that can break off, they get filtered by the liver. And so that's how most tumors will frequently at least see the liver at some point. Whether they choose to stay there and make a new home or not is something that we're trying to understand. And that's where kind of the concept of tumor microenvironment comes in, and different patient and tumor related factors as to why certain people will have metastases to the livers and others may not. It's an evolving area of interest and understanding, which we don't fully have as of yet. But it doesn't, the tumor doesn't typically spread from your lymph nodes into the liver. There's direct blood flow that goes into the liver from where the tumor was being drained.
Got it. Thank you. Great question. From Pat, have you seen any great results with cabozantinib with liver nets?
I personally, we haven't put a lot of patients, as far as I know, on cabozantinib. That might be a question better answered by a medical oncologist.
Yep. Thanks, Pat. From Shane, there's often talk about pancreatic nets behaving differently than others. Does this mean a P-net with a Ki-67 of 1% will grow faster than an SI net with Ki-67 of 1%? Or do P-nets just often present with higher Ki-67s?
I think that's a two-sided question. One, as far as we know biologically, a PNET versus an SINET with a low Ki67 index should essentially behave in the same fashion. But again, no two tumors are necessarily identical. So I think to say that they do or don't is a very, very broad generalization. We do think that there's some components within the pancreas that make it more resistant to our innate immunity being able to identify and find these tumors more quickly, which is why they do present in a more aggressive fashion. And I don't necessarily think that they present with higher Ki67s per se, but they may present in a more advanced fashion than a small bowel net and maybe faster growing in that sense.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, the Carcinoid Cancer Foundation program. We're here with Dr. Alexandra Gangi from Cedars-Sinai out in Los Angeles. And I wanted to make mention, talked about this briefly at the very beginning of the program, all the videos that I've done over the past 10 years for CCF. That's a resource for you, a free resource, a library, a database of videos that exist here on the Facebook page under the videos tab and also on the YouTube channel. And I say this every week, it seems like if there's a topic, there's a big chance that we've covered it in a video where we go into a little bit more depth than we necessarily can here today. Surgery is one of those. And so just some of the conversations we were having today, specifically about Whipple procedures, et cetera, we had a video on surgery. We featured several doctors around the country, Dr. Rodney Pommier, Dr. Mark Lewis, who had the Whipple procedure himself. So he really explains it very well. And there was one other doctor who was in that video. I can't remember. Oh, Dr. Gangi. So I encourage you to use those resources. We've worked long and hard for many years to create those for you. So just mentioning that if you have follow-up questions or something we can't go deeply into today, we have plenty more resources for you. So I encourage you to utilize those. From Rebecca, how much of the small intestines can you have removed and still live?
Yeah, so typically we want to leave you with 90 to 120 centimeters of small intestine. Everyone varies a little bit in terms of how much small intestine they have. I've had some patients that have had as little as 200, and I've had some patients who have had as many as 450 centimeters. So typically when we're doing these resections for small bowel neuroendocrine tumors, we want to manually palpate the small bowel because sometimes these tumors can be as small as a sesame seed. And people don't believe me when I tell them that. So I've taken pictures of patients who have allowed it just to prove that, yes, they can literally be a few millimeters in size and you can sometimes feel them manually, which is why we don't always recommend robotic and laparoscopic surgery because we don't get any good haptic feedback when we're using minimally invasive surgery techniques. But usually when we do this, and if we identify multiple different tumors, the one thing we do before we cut is evaluate how much remaining small bowel you have. I have not been in a situation as of yet where I've been limited in terms of being able to take out the tumor because we weren't leaving enough small bowel behind. But for appropriate and adequate absorption of your food, making sure you get the right nutrients and vitamins, you need 90 to 120 centimeters of small intestine. 90 is cutting it close. We prefer 120, but.
Understood. Thanks, Rebecca. Great questions so far today. Eva has chimed back in. This was the question earlier about the frozen pathology and the receptors. She says, I just wanted to know if I need this. I just wanted to know this if I need treatment in the future. This would open me up, or this would open up for PRRT, correct?
Yes, it would open you up for PRRT. But if you were to need treatment in the future, if you had any progression of or recurrence of your disease, given that I don't know what the situation is, you can always have the gallium scan at that point, and it would tell you if you were receptor positive.
Got it. Thanks, Eva. From Mark, if you are not SA positive, a gallium-68 scan would not be of any diagnostic benefit. Is that correct?
Yeah, typically won't pick up the site of the tumors. We have some patients who have mixed tumors, and we have others in whom the tumor sensitivity can sometimes change from being gallium positive to gallium negative as the tumors differentiate. So there's variation, but generally speaking, you are correct.
Thank you. Next question from Jennifer. What is the most common time amount you see reoccurrence? So I'm guessing that's maybe like, what's the most common window that it happens within?
Right. I think impossible question to answer because it depends essentially on grade, differentiation, tumor type, location, what we're talking, if you presented with metastatic disease or not. So it's a difficult question to answer. And I've had patients who recur within 6 months, and I've had patients who, don't recur for 10 years.
Okay. Similar question. RM says, what is the longest survival from date of diagnosis you've seen in stage 4 NEC? It's kind of specific.
So as a surgeon, we very infrequently get the grade 4 NEC patients because the mainstay of therapy for that subset of patients is systemic therapy, because we know that they could be aggressive. A lot of times patients will present with metastatic disease, which doesn't necessarily make them amenable to surgical resection. I have had a few patients in whom we've been very successful with the systemic therapies that they've received, and they have residual tumor at certain sites that may continue or start to grow. So the longest surviving patient that I have who has had an exceptional response to therapy and surgery is now going on 4 years.
How many?
4. But I think that's an exceptional responder, right? So
Yeah.
I wouldn't say that as the standard, but I've seen as little as 3 to 6 months, unfortunately. And my longest patient is a 4-year. But this is, again, a patient that I, as a surgeon, got to see for NEC, which is not a common scenario.
Right. Got it. Next question from Tina. A primary tumor in the pancreas tail was removed, but now the primary tumor is regrowing. Surgeon didn't get it all. Now surgeon wants to go in and remove it and to fix hernias that came after the last surgery. Is the goal to get the primary tumor? Is it the one that spreads the cancer?
The primary tumor is the one where the other cancers come from. Yes, and the goal should be to get the primary tumor.
So now it's regrowing. The surgeon didn't get it all, so they want to go in and remove it. Is that typically what one would do in that situation?
Yes, I'm assuming when she says it's regrowing in the site that it was removed. And sometimes when you do, there's different procedures you could do for pancreatic neuroendocrine tumors, or something called the nucleation, where you essentially try to get right around the tumor itself and cut it out. And then there's another type of procedure, we would call it an anatomic resection, but depending on where it's sitting in your pancreas, we take kind of that healthy portion of the pancreas out with the surrounding tumor. That's the way we treat your standard pancreatic adenocarcinoma, because we don't want to just pop out the cancer, because we're always afraid that it has kind of finger-like projections into the healthy pancreas. Neuroendocrine tumors typically don't behave that way, which is why we can enucleate them. But sometimes with enucleations, you can have recurrences at that site, or if you were doing a formal resection, meaning you were taking out adjacent healthy pancreatic tissue, if you had a little bit of extension in the tumor right along where you cut, you can have recurrence there. So if that's the sole site of disease, that's the only place that you've recurred, it would make sense to go back and try to get that all out if it's surgically feasible.
Now you don't work with lung nets at all, do you?
No.
So
I mean, I do if they're metastatic to the liver.
Yeah, copy. Got it. But I think we did this in that video that I was talking about earlier. Could you go through, you kind of alluded to a few of them in this recent answer. Could you explain some of the different surgical approaches that one could use or that's available? Types of surgery?
For what kind of tumor? For all of them? Okay.
Yeah,
we'll just start with
a foundation.
Sure. So if you have a small bowel tumor, typically we want to take out the tumor in the small intestine with all of the adjacent draining lymph nodes. So that means we cut out your intestine, cut one side, cut the other side, cut kind of a pizza slice in between that goes into where the blood vessels and the lymph nodes are, and then we reconnect those two edges of intestine. So that's with respect to colon, small intestine, rectum, et cetera, if you're a candidate for surgery. With respect to the pancreas, we kind of think of the pancreas in 3 parts, really in 2, but in 3. It kind of has a head. So it goes from essentially the right side of your body sitting right underneath your liver, all the way over to the left side across your mid-abdomen from the liver to the spleen. And if you kind of think of it, it has a head portion, which is the part that's sitting by the duodenum and the liver. And then it has its neck, which is kind of the mid-body portion. And then it has a tail, which is sitting right next to the spleen. So depending on where a tumor lies, it requires potentially different types of operations. The pancreas itself has a pretty important duct that sits right in the middle, and that's what drains all of the pancreatic juice and dumps it into your small intestine so that you could break down protein and food and different things. And right where that duct empties into the small intestine, you also have a duct from the liver that drains and dumps bile in there. So that's kind of in the head. So the head is anatomically kind of the most critical portion of the liver because it's so connected to kind of the small intestine and everything else. So when a tumor is in the head of the pancreas, its location is important because if it's on the very edge of the pancreas, either up above, way high above the duct, or very low down away from the duct, you can, and it's small enough, under 2 centimeters, you can consider doing what we discussed a minute ago, which is that enucleation procedure, meaning you just try to get that particular lesion out. That way you can actually preserve a majority of the pancreas and you don't have to kind of put everything back together. So when Rain alluded to Dr. Lewis having had a Whipple on that other surgery procedure and him describing it well, what his operation required is that they took out the head part of the pancreas, they took out the adjacent small intestine, and they took out part of the bile duct that comes in to that part of the small intestine from the liver. And so when you cut that whole part out, those things are now not connected to anything else. So you have to reconstruct it, meaning we have to bring up a loop of small intestine and reconnect the remaining pancreas, the bile duct, and the stomach or the proximal duodenum, essentially to all of those other sites. If the tumor, again, is in the mid-body, depending on how close or far it is from the duct, you can sometimes consider doing a distal pancreatectomy or an enucleation. That means you cut out the other half of the pancreas that goes towards the spleen. And then a lot of times you can preserve the spleen unless the tumor is immediately adjacent to it or touching it. That's a very general description that's much better with pictures, but
pictures are always nice.
Yeah.
Michael says, my liver is starting to hurt. What is a safe pain reliever?
The liver doesn't actually really have pain receptors. So if you have pain kind of on that right side, it could sometimes have, sometimes if you have large tumors, they can sometimes stretch the capsule and you can have some pain from that. And other times it could be from rubbing against the peritoneum, which is the lining of the abdominal cavity, which does have pain receptors. But it's not necessarily specific to knowing that your liver hurts. There could be other things there. So I would recommend that you get checked out to make sure that that's exactly what's going on and it's not something else. And typically we will recommend different anti-inflammatory medications. So I'm not suggesting that you go and take those, but if you're having a lot of pain, you should talk with your team and they can direct you in terms of what to take.
Thanks, Michael. Next question from Kat. I'm a rare case and I struggle to find anyone going through anything similar or it being covered on any of the recent videos or live videos. I'm sorry to hear that, Kat. We're going to try to help you. I have VIPoma, tested positive on 3 NET tests showing evidence of NET disease on and all the symptoms. There's a lot of case-specific stuff, so I'm just going to skip to your question, Kat. My question is, have you ever known anyone have elevated VIP and all of the symptoms of a NET and struggle to find the tumor? Any advice would be amazing.
I'm assuming based on the fact that you seem to know what's going on. Have I known anyone who struggled to find the primary tumor? It certainly can happen. Sometimes these tumors can be unbelievably small, but the typical metrics we use are essentially imaging with standard gallium scanning to see if it'll show up that way. If not, you can consider a PET. Sometimes there's non-specific uptake in the pancreas that can make it complicated. Endoscopic ultrasound, meaning you do an EGD and then you use an ultrasound at the time. They can look at kind of the pancreas. Sometimes we will consider doing a laparoscopy, meaning a surgical intervention, again, kind of looking more closely with an ultrasound directly on the pancreas to try to identify it. But those are essentially the standard ways. And I personally have not had experience with really not being able to find it. But as you know, and you mentioned, VIPomas are fairly uncommon. So typically by the time they're sent to me, something has been identified.
And she does say that initially it seems as though my tumor ghosted out and they couldn't see it. I'm awaiting another gallium scan. I do have a tumor on my liver, but I've been told it's benign. So yeah, if you're struggling to find it, what move do you make next?
all of those things I mentioned.
Mm.
So I guess they're waiting for another gallium scan. I don't know if she's had an EGD and an EUS. If they've tried an ultrasound, you can consider a surgical ultrasound procedure, exploratory surgery. I mean, all of those things are options, but it depends on to what degree you've exhausted all previous non-invasive options.
Sure.
And obviously, if she's having symptoms, we would want to find it so we can get this thing out to make her feel better.
Well, thanks, Kat. Let me know if you have a follow-up question to that, or if you have tried some of those other options that Dr. Gangi mentioned. From Michelle, do you have patients who get constipation after GI surgery? What are some of the causes of that, especially if patients were told to expect to have diarrhea post-operation instead? Do you recommend lysis of adhesions after there is evidence of adhesions, and do you think this would help with constipation?
Reasons for constipation are certainly many. Most often post-operatively, it's secondary to high narcotic use, because narcotics can be significantly constipating. Sometimes you just are not eating or drinking as well, so you're dehydrated, which also doesn't help with constipation. And in terms of diarrhea, we sometimes will mention that you may have looser stools depending on what was removed, the type of operation that you've had, just because your absorption changes. But yes, you can experience constipation. It could be secondary to adhesions, as you mentioned, meaning scar tissue in the abdomen after surgery. The risk of scar tissue development in the abdomen after surgery is about 20% with any operation, and that's kind of a lifetime risk. It doesn't really get better or go away. And it can manifest at any point. Depending on constipation alone is not an indication to go in and do lysis of adhesions, because they may be completely unrelated. Sometimes patients have underlying GI motility disorders, meaning your intestines just don't move normally. You may have slow motility of your colon or small intestine that sometimes are exacerbated with surgery. So there's different types of tests and imaging tests that we could do to evaluate if there's some kind of a problem, like does something get hung up in one particular part, and is that secondary to an adhesive band, or does your gut just not function the way it normally should? And based on some of those tests, and if this is a prolonged problem, then you may consider different treatments. We have some drugs that can help with motility. We'll do that occasionally if we don't have a good understanding of what's going on. But generally, we'll tell you to hydrate, try some over-the-counter things like, daily Miralax, which I like to use for my patients who have constipation issues, and essentially see if some of that can be resolved. If ultimately you have bowel obstructions and that's resulting in what we're calling constipation, then sometimes surgery to remove those adhesive bands might be necessary, but a lot of the time we prefer not doing that if we can, because these things will self-resolve.
Got it. Well, thanks, Michelle. Let me know if you have another question. From Ariane or Ariane. Before I found out I had stage 3 NETs, small bowel and mesentery, I was set up for a bariatric surgery. That was canceled due to cancer removal surgery being priority. Now that I'm on surveillance, is bariatric surgery off the table?
Bariatric surgery is not necessarily off the table. Depending on the type of bariatric surgery you were going to have, that plan may need to be modified, just because sometimes the intestines have to be rerouted, like you're having a gastric bypass. Your intestines kind of redo the anatomy of your plumbing. If you're having something like a sleeve, we're just taking off a large part of the stomach. So adjustments may need to be made in that respect, depending on the type of surgery you're going to have. Sometimes different institutions have different standards in terms of wanting to know that you're cancer-free for a period of time before doing another procedure that's not necessarily urgent or emergent. So sometimes that window is anywhere from 6 months to a year to make sure that on surveillance scan there's been no changes with respect to your primary tumor. But is it off the table 100%? Not necessarily. I would talk to your bariatric team, wherever it was that you were seeing them, and see what their requirements are.
All right. Thank you for your question, folks. We got about 20 minutes left, so keep them coming. Quick side note, I've been getting a lot of questions about lung nets today. That is not Dr. Gangi's specialty, but I just wanted to make mention that in a couple of weeks, man, this year's going by so fast. I think in the beginning of October, we're having on Dr. Robert Ramirez again, who is a lung net specialist. He's been on the show 2 or 3 times now. So we will cover that, because we've been getting a lot of it seems like a lot more lately questions about lung nets. So Yeah, just wanted to mention that. Next question from Shane. If liver tumors are treated with ablation, will there always be evidence of that on scans, or would the liver heal completely, making the area look good as new? And several other people were interested in this as well.
Yeah, sure. I think it depends on the size of the tumor and the size of the ablation zone. So typically, when we're treating a tumor with an ablation, we want it to be 3 centimeters or less. And then when we're doing the actual ablation, the way we treat the tumor is we try to put the probe either kind of central, or we put it in 2 different sites in the periphery. And then we want a zone of about 1 centimeter to 1.5 centimeters around it to be treated. So we're treating some normal, healthy liver tissue as well. So we kind of have a margin. So you can imagine if you have a tumor that is larger that was ablated, it's not uncommon on the follow-up scan that it's going to look like the tumor grew. So if you go to an outside hospital and they scan you, they're going to say, oh my God, your tumors grew. And we have this conversation not frequently in the immediate post-operative period. And as you can imagine, because we just made the tumor look bigger, it actually takes a lot longer for it to go back to looking small. Over time, it can certainly get smaller, but typically you will see some residual area of differential uptake on an appropriate scan. But if it was teeny tiny, right, like sometimes we have, if we're lucky enough to be able to see them on ultrasound quite well, if you have like a 0.5 centimeter tumor that you've ablated, that surrounding zone is going to be smaller. So it's much more likely that something like that ultimately would disappear in the course of 3 to 4 years if you're doing surveillance scans compared to something that was originally big. Hopefully that answers your question.
Got it. Yeah, let us know if that answered all of your question. And if not, go ahead and chime back in when you get a chance. Thanks very much. Next question. Oh, where did I just see that? From Tina. When getting ready for another surgery, this is in the area of the pancreas, what should a person do nutrition-wise to get to prepare to get ready? E.g., eat more protein, something like that. Like, is there anything that they should do leading up to that?
I generally will counsel my patients to just try to eat a healthy, balanced diet. So, if you're a fast food fanatic and that's what you eat for dinner every day, then I would recommend switching to salads and things that are higher in protein. It's okay to also have carbs. Ideally, you want to eat in a healthy way. Most centers have nutritionists with whom you can speak to if you feel like you need to modify it. The other thing is I typically recommend increasing your activity. So I will require that my patients, depending on what their baseline level of activity is, try to get at least an hour to an hour and a half of some kind of cardio. Cardio can mean you can walk for an hour. So a lot of people will do that. And I think that gets you stronger for surgery and for your recovery overall. But there's no specifics in terms of having to eat more protein or less carbs or anything like that.
Got it. Thank you. Next question from Jennifer. What are some symptoms of rectal and small bowel nets?
A lot of times rectal nets will be asymptomatic unless they're large and bulky, and then that'll just feel like you either will notice changes in the caliber of your stool depending on where it's located. Some people may notice a little bit of bleeding just because it's like having kind of a knee scrape on the mucosa of the small intestine every time something passes next to it. You may have some bleeding that you notice. That's no different for a rectal net versus any kind of a rectal cancer. So those are kind of red flags when you notice changes like that, or if you feel like you're not able to pass gas or have bowel movements. But usually that means that there's a lot of tumor bulk. For something that's teeny tiny, typically you're not symptomatic, and it's why we will find these incidental rectal nets on colonoscopy, because I'm sure you're all getting your colonoscopy starting at the age of 45. And if you haven't ever had one and you're on the show, please go get one. That's one. With respect to small bowel neuroendocrine tumors, again, a lot of patients may not have symptoms secondary to the primary tumor alone, because frequently, like I said, they can be very small, and sometimes patients will only have symptoms after they've metastasized to other locations, whether it be the lymph nodes or the liver. The lymph nodes, because the lymph nodes kind of tether what's called the mesentery, which is the fat pad that has all the blood vessels and lymph nodes that drains the small intestine. And sometimes that can get shortened because there's big tumor bulk in there. And sometimes that can cause abdominal pain. If you have a big enough, bulky enough small intestine tumor, again, you'd have the same type of symptoms of when you eat, you either may feel full too quickly. You may have abdominal pain and cramping and discomfort. You may ultimately notice that you're kind of losing weight and you can't get enough food in, kind of things of that variety. They're non-specific, which is why it's difficult to find.
Got it. Thank you. Question from Bob says, is there an upper age disqualifier for PNET debulking with liver mets, given the patient is relatively healthy otherwise?
In my opinion, age is just a number, and it really depends on the degree of disease, what the debulking may require, and your ultimate overall health. Sometimes in patients with metastatic disease, we'll have something known as carcinoid heart disease, and that may manifest the longer that you've had a hormone-producing neuroendocrine tumor. And when we're looking at patients for potential debulking procedures, sometimes that's a disqualifier, but not specifically age as a number.
Got it. Hey, thanks, Bob. That's good to hear. Hopefully that helped answer your question. If you have any other ones, let me know. From Barbara, I had ovarian cancer and was told that it started in my lower intestine. I've been on lanreotide for 3 years now. What is the lanreotide doing that can't be done with surgery? Can the tumors be removed?
Did you say she had ovarian cancer that started in her intestine?
In her lower intestine, yeah.
Yeah, I'm unclear. Ovarian cancer and neuroendocrine tumors are slightly different, so I'm not sure if you're saying that there's cancer in your ovaries that we think is coming from the neuroendocrine tumor that started in the lower intestine. But I would need some clarification on that to answer. Generally, lanreotide or any type of somatostatin analog is a cytostatic therapy, meaning it's something that we give because we think it slows the progression of tumor. It doesn't actually kill anything that may be there. So if surgery isn't an option for you, it has nothing really to do with the lanreotide. I would need to know the nuances of what's going on in your particular case.
Yeah. So Barbara, if you have any more information about that, we still have about 10 minutes left. So try to get that back to us if you can. From Deborah, what is a side branch IPMN of the pancreas? Could a lesion as small as 6 millimeters cause severe symptoms of abdominal pain, swelling, nausea? Can something that small be surgically removed? Or what would be the appropriate follow-up if you have a lot of pain already?
A side branch IPMN. So we mentioned earlier that the pancreas has a main duct that essentially drains all of the pancreatic juice into the small intestine. And that main duct has multiple different branches that come off of it and ultimately takes the enzymes from individual pancreatic cells. So if you think of it as kind of leaves on a tree, those are the individual pancreatic cells. And then if you look right at one particular branch, it has many, many, many tiny branches that kind of feed off each leaf. A side branch IPMN is one of those side branches off of the main trunk of the tree. An IPMN is an intrapapillary mucinous neoplasm, which means it can be pre-malignant. With respect to side branch IPMNs, typically if they're small, and 6 millimeters would classify as small. If they're under 3 centimeters, we typically watch them because although they may have a predilection to turning into something, they do it unbelievably slowly, and doing pancreatic surgery sometimes causes more harm than benefit in the setting of something that may not change within your lifetime. So there's very specific guidelines in terms of how and when to resect side branch IPMNs. Can I say that no, it doesn't cause all of the symptoms you've mentioned? No, because I can't ever definitively say yes or no to anything in medicine. That's why it's called the practice of medicine, and everyone's a little bit different. But it would be very, very, very unlikely. And it's not typically something we will see.
Got it. Thank you. Just a clarification question from Stephen. Did Dr. Gangi say the mesentery does not seed the liver?
The mesentery feeds the liver because that's where the vessels are. I said the lymph nodes don't necessarily feed the liver. Lymphatic drainage doesn't necessarily go into the liver.
Got it.
But the veins drain into the liver. And in the mesentery, you have lymph nodes, lymphatic ducts, veins, and arteries.
Got it. Hey, thanks, Stephen. Hope that clears it up. From Rose, is there an advantage of taking lanreotide over somatostatin?
I would discuss that with your treating physician.
Got it. Thanks, Rose. I have a question, like looking forward into the future or things that might have just currently came out. Are there any new surgical tools or things that are coming down the pipeline that would help you do your job better that you're excited about?
Excited about a lot of things.
Tell me,
I think
tell me about them.
we're certainly getting better at doing with respect to the liver, more parenchymal sparing, meaning sparing healthy liver tissue types of surgeries, being more specific in terms of using better techniques for ablations and things of that variety. I think we have some techniques for using radio-guided surgery, which helps us better identify the anatomy intraoperatively by using imaging studies done beforehand for surgical planning. None of these are necessarily specific to neuroendocrine tumors, but I do think they're all helpful. In addition, I think we're certainly becoming better versed at using minimally invasive techniques for multiple different types of complex operations. The one caveat for neuroendocrine tumors where we haven't really found a way to get haptic feedback is it doesn't really change management of small bowel tumors, because we still have to make a small incision and manually palpate, because like I mentioned, those are small. Using different types of injectable materials like indocyanine green to identify potentially draining lymph nodes within the small bowel, or even for pancreatic tumors, or some things that we've used where we're evaluating the utility of those types of treatments, again, to do more both liver and pancreas sparing tissue surgeries and taking out the appropriate lymph nodes that would help us. Certainly, we have gotten better in our endoscopic techniques. So in some patients who may have small bowel tumors that are very proximal in the small bowel tract, like in the duodenum, we have ways of resecting those basically intramucosally through the inside, so that you don't have to have a surgery. That goes for rectal nets too, that are accessible through that mechanism. That's about all I could think of from a surgical perspective.
Got it. Thank you. From Lisa, do you know what the next step would be with a grade 1 well-differentiated 2 millimeter in the duodenum, dotatate PET scan, traditional PET scan, or something else for further diagnosing tests? Do you see isolated tumors that require only surgery in the duodenum often?
Yeah, so she said 2 millimeter?
Yes.
Yeah, so we will not infrequently find small NETs in the rectum and in the duodenum that are identified at the time of an EGD or a colonoscopy. And typically these could be very small. So if you have a skilled endoscopist, they look and they see kind of this, usually it's a yellowish papule, and they'll biopsy it, and then essentially we get information back that it was a very, very small net. We have to imagine that typically when we do that resection endoscopically for something like 2 millimeters, it's typically entirely resected by the time we actually see it. So the recommendation, which it sounds like she had, is to get a gallium to make sure that there's no residual uptake at that site, and then a repeat endoscopy, typically within 6 months to a year, to make sure that there's no area of regrowth there. That's kind of our standard algorithm for these small incidentally found neuroendocrine tumors of the duodenum and the rectum.
Got it. Thank you. Debbie asked what center you were with. Debbie, she is with Cedars-Sinai in Los Angeles, but a pleasure to put a name with the face, Dr. Gangi, she says. What do you tell a first, many of the people on the show are here every week. They've been dealing with this for a while, but every week, inevitably, we get someone who just got diagnosed very recently. They might have just found the show. They're scared. They're confused. What is your advice to a newly diagnosed patient with a NET?
Sure. My advice to a newly diagnosed patient with a NET is first, breathe, take a breath.
Solid.
To do a little bit of your research, but don't go crazy on Dr. Google. There's some really, if you're here, you're probably savvy enough to have found good resources. We're fortunate in that there's some very good resources for patients with neuroendocrine tumors, and some really excellent patient advocacy groups where there's an opportunity for kind of education and for connecting with others who may have dealt with what you're dealing with. We will typically recommend trying to identify an expert within your area who has managed neuroendocrine tumors before, because they are rare. This doesn't mean that the person that you're seeing or working with can't continue to treat you, but sometimes it's helpful to just get more questions answered and get directed in the appropriate way. I will tell patients if they meet me and they don't like me that it's okay to get additional opinions. You're going to have to probably stay with your team of doctors for some time. So our job is really to kind of empower you to make the appropriate decisions for you, because although I may think something is a good idea, that might not necessarily fit in with what you're thinking is most beneficial for you. So my job is to just give you all the options and say, this is what I think, what I'm thinking. And then ultimately you can meet with other people to identify if that's the appropriate thing for you. And ultimately you will need a team of people treating you. So you want to make sure that you've kind of looked at all of the different areas. As we mentioned on the show, there's multiple different options for different types of neuroendocrine tumors. And that may require, a medical oncologist, a surgeon, an interventional radiologist, or a nuclear medicine specialist at different time points. And so you want to identify who those members might be early on. But I think that's my general recommendation. There are typically options, and although it could be frustrating that you don't have the perfect answer in terms of this is plan, this is what we're going to do first, second, and third, and it might look like a little bit of a circle depending on a few different things, that's not necessarily a bad thing. I think that sometimes scares or frustrates newly diagnosed patients, but I think those are all positives in my opinion, that we have multiple different options to explore at different time points.
Got it. Thank you. Our friend Ajid says, thank you, Dr. Gangi and Rain, for this informative session. Rebecca says, thanks for your knowledge and your time. You guys rock. Hey, everybody out there, I have a favor to ask. At the bottom of the screen, if you hover over it, gives you a few different icons and images you can use. Go ahead and click on the heart and send a bunch of hearts to Dr. Gangi, because she stepped away from the OR today, folks, to make the show. So we got to really thank her for her commitments for being here. But if you appreciated today's show, go ahead and let us know with those little visual cues. It helps so much. Dr. Gangi, thank you so much sincerely for being back on the show. It was a pleasure seeing you again.
Likewise. Thanks for having me.
Absolutely. And thanks to you folks at home. As always, we hope this program helped answer some of your questions. Again, I'll reiterate, if you have follow-up questions, please reach out to ccf@carsonway.org, or here on the Facebook page where you already are. You can send them a private message. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. And finally, my name is Rain Bennett. Thank you for watching. I have been your host, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye.